Hi students, I'm Dr. Sakshi Arora Hans, your OBGY faculty at Marrow, and today I am here with the INI-CET November 2022 Obs and Gynae recall. Now for the first time, INI-CET was conducted in 2 sessions. And if you talk about OBGY was balanced in both the sessions. Rather, I would say that the difficulty level of Obs and Gynae questions, the topics of Obs and Gynae questions, both of them were quite a lot of them were overlapping. Now, about the questions which had come. See, all the questions which had come in Obs and Gynae, they were from the areas which we always tell are important. So nothing came, as you say, out of syllabus in Obs and Gynae. Everything which had come was from the syllabus, and around 90% questions were from what I had taught you in Marrow. So when I'm going to give you this recall, I'm also going to show you that where exactly in the videos you could find that answer. So let's start with Obs and Gynae questions recall first session. Now this is the first question. First question which we are doing is the following are correct regarding normal placenta except a very, very basic question related to placenta. Now everything about placenta I had already taught you in the video on placenta. So there is a video on placenta, there is a video on placental hormones, and there is a video on placental anomalies. So as you can see over here, these are screenshots from those videos, and over here I have told you that the weight of placenta at term is 500 grams, and then at term, if we see the ratio of weight of placenta is to fetus, it is 1:6. And at what time in pregnancy, weight of placenta and fetus are the same? That is at 17 weeks of pregnancy. So weight of placenta, 500 grams. That's an absolutely true statement. Coming to the diameter of the placenta, again, from these screenshots, you can see I have told you that the diameter of the placenta is between 15 to 20 centimeters. Some of the books mention it as 15 to 22 centimeters. So over here, it's round and oval in shape with 22 centimeter diameter. That's also a correct statement. Central thickness of the placenta. So as far as thickness of the placenta is concerned, it is 2.5 centimeters and it may go up till 4 centimeters. If the placental thickness becomes more than equal to 4 centimeters, that is what is called as placentomegaly. And in the videos also, I keep on telling you that it's very important for you to note the causes of placentomegaly, which are high fetal cardiac output situations like fetal anemia and hydrops fetalis. And all of you know that hydrops fetalis occurs in Rh negative pregnancy, twin-to-twin transfusion syndrome, and parvovirus B19 infection. Other than that, a big placenta is seen in maternal diabetes. Big placenta is seen in molar pregnancies. It is seen in intrauterine infections. The most common intrauterine infection which is associated with placentomegaly is syphilis, and the second most common one is cytomegalovirus. Then there are certain placental conditions like placental mesenchymal dysplasias and cholangiomas which can lead to a big placenta. Right? So this statement over here that the central thickness is more than equal to 2.5 centimeters, that's absolutely true. Then it has extra placental membranes and a 2-vesseled umbilical cord. That's an incorrect statement. In the video on umbilical cord and its anomalies, I have told you that initially in the early periods of gestation, there are 4 vessels which are present in the umbilical cord. Right umbilical artery, right umbilical vein, left umbilical artery, left umbilical vein. And as the development progresses, then it is the right umbilical vein which disappears, left umbilical vein is left behind. So when a baby is born, the umbilical cord has got 3 vessels. Left and the right umbilical artery and left umbilical vein. So this statement over here is incorrect, right? Now, with respect to placenta, I would also want you to remember in which conditions are the placenta, size of the placenta small. Size of the placenta is small in case of uteroplacental insufficiency, and you know that uteroplacental insufficiency is seen in PIH, it is seen in IUGR, and in constitutionally small babies also the size of the placenta would be small. right? So that was a pretty easy question. Coming to question number 2, which is again directly from your notes, which of the following suggests primary amenorrhea? So primary amenorrhea, as I have told you so many times, it is no menarche by the age of 15 years in presence of secondary sexual characteristic. And the most prominent secondary sexual characteristic which we have to see is the breast development, or it is no menarche by 13 years of age in absence of secondary sexual characteristics, right? That is how you define primary amenorrhea. Now, in primary amenorrhea, I have also told you that for breast and pubic hair, there is a Tanner staging, and there are 5 stages of Tanner for breast development and 5 stages for pubic hair development. I have also mentioned to you in the video on puberty that whenever breast budding happens, breast budding is the first visible sign of puberty in females. Although if they ask you which is the first sign of puberty in females, then that is going to be growth spurt. But the first visible sign of puberty in females is breast budding, and breast budding corresponds to Tanner stage 2. So whenever we say that secondary sexual characteristics are present, it has to be Tanner stage 2 or anything more than that, right? Similarly, when we talk about pubic hair development, the important thing which you have to remember is that in stage 2, pubic hair are going to be seen along labia majora. That is the first time when pubic hair are going to appear, and they are going to appear along labia majora. But most of the times they ask you that in which stage is pubic hair seen on mons pubis, and that is seen in stage 3. Right? Please remember, breast development takes around 3 to 3.5 years, and the size of the breast doesn't indicate its maturity. Right? So over here, the question was an 11-year-old girl with Tanner stage 1. Tanner stage 1 means absent secondary sexual characteristics. So for absent secondary sexual characteristic, the age criteria was 13 years. So option A is incorrect. Option B, 13-year-old girl with Tanner stage 5. That means a fully developed breast. That means secondary sexual characteristics are present. And if secondary sexual characteristics are present, then the age for defining primary amenorrhea was 15 years. Right? So this is also incorrect statement. 14-year-old girl with Tanner stage 1. Now, just now I told you Tanner stage 1 means absent secondary sexual characteristic, and for absent secondary sexual characteristic, the age is 13 years. So definitely if the female is 14 years of age with absent secondary sexual characteristic, she fits into the definition of primary amenorrhea. So the correct option over here is option C. 12-year-old girl with Tanner stage 4. Stage 4 will mean secondary sexual characteristics present, and for secondary sexual characteristic present, the age group is 15 years, right? Now, I also want you to remember something which I had told you, that Williams 4th edition Gynae, that's the new edition of Williams which has come. It has again given some revised definitions for primary amenorrhea. And that is if there is absence of menstruation by 15 years of age, that is primary amenorrhea. If there is absence of menstruation within 3 years of thelarchy. Right? Normally, the age difference between thelarchy and between menarche is 2 years. But if 3 years have passed and breast budding appeared, but within 3 years of breast budding, menarche hasn't appeared, then that is also primary amenorrhea. And a third very important definition which you have to remember, because these are new definitions, these are new updates which you have to remember, that if a female has not menstruated by 14 years of age and she is showing signs of hirsutism, excessive exercise or eating disorder, then that is also considered as primary amenorrhea. For secondary amenorrhea, if there is absence of menstruation for 3 months in a previously menstruating female, that is the definition for secondary amenorrhea. Although you should start investigating if a female is having less than 9 cycles in a year, right? Now, The other very important thing which I want all of you to remember is that how do you proceed once you diagnose a case of primary amenorrhea? Whenever a patient of primary amenorrhea comes to you, the first thing which you have to do is a thorough physical examination, which should consist of seeing how the breast of the child are, whether the breast budding is present or not, what is the Tanner stage for breast development and pubic hair development, and you should also look at the external genitalia. Second step is urine pregnancy test. Please remember that urine pregnancy test is not only very important for secondary amenorrhea, it is also important in patients of primary amenorrhea, especially if breast development is complete. Because it could be that that female is a case of incest, and a case of incest is never going to tell you, she may be pregnant and she's never going to tell you that she is a case of incest and she has become pregnant by her own family member. She is a small child and she will come to you as a case of primary amenorrhea. So whenever breast development is present in a case of primary amenorrhea, it becomes important for us to do a urine pregnancy test. Then the third thing is you have to do ultrasound to see the gonads and to see whether uterus is present or not. And then you also have to do her hormonal profile where you are going to check the levels of FSH, right? So this is the sequence in which you have to proceed with the tests whenever a female comes to you with a primary amenorrhea. Although if the question is asked that which is the best investigation or which is the confirmatory test for primary amenorrhea, undoubtedly the answer is karyotyping. Clear? Coming to the third question, which is again directly from your notes, what can be used in first trimester MTP except? So all of the following can be used in first trimester MTP except. So the methods of doing MTP, as I have told you in the video on abortion, there are first trimester methods and second trimester methods. In the first trimester methods, we have medical abortion. Medical abortion is done using mifepristone and misoprostol. So this option over here is a correct option. Then suction and evacuation using a Carman's cannula, manual vacuum aspiration and menstrual regulation. So manual vacuum aspiration is a method of first trimester MTP. Suction evacuation, and if suction evacuation you are not doing, then dilatation and curettage can also be done in first trimester. Coming to second trimester methods, in second trimester methods you have medical abortion, and in this category of medical abortion you are going to use prostaglandins, and the most commonly used prostaglandin for this purpose for second trimester abortion is only misoprost. Then you may go for extra amniotic ethacridine instillation or intra amniotic saline, or you may use oxytocin, and then you may also go for dilatation and evacuation. Please remember, dilatation and evacuation in second trimester is done using ovum forceps, right? So over here, extra amniotic instillation of ethacridine, that is a method for second trimester MTP. It is not a method for first trimester MTP, although it is not being done these days. But still, you have to remember the methods for first trimester MTP and for second trimester MTP. Remember, up till 7 weeks of pregnancy, the best method for MTP is medical abortion using misoprost and mifepristone. Between 7 to 12 weeks, the best method is suction evacuation, where a Carman's cannula will be connected to suction machine, and the pressure which is going to be generated in the suction machine is 600 millimeters of mercury, and the Carman's cannula which you are going to pick up should correspond, the number on the Carman's cannula should correspond to the period of gestation. Right? The endpoints of suction and evacuation are there will be decreased blood loss, there will be a gripping sensation, where the internal os, once the uterus is empty, once the product of conception are all out, the internal os starts closing, and so you get a gripping sensation on the Carman's cannula. When you are doing the evacuation, you get a grating sensation and you can see air bubbles in the cannula. So these are the points, these are the indicators that yes, the suction evacuation is complete. Clear? So over here, the answer was option C. All of you should remember the protocol for MTP, medical abortion up till 7 weeks, and medical abortion between 7 to 9 weeks. That's again a very, very important thing. In this question, I would also want, whenever you are doing this question, revise. the MTP law and the amendment which was made in 2021. That is also something which you have to remember, right? Coming to all our causes of uterine dysfunction except. Now, INI-CET is very, very fond of picking up questions directly from Williams tables. There were 2 or 3 questions which were directly from tables given in Williams in your main exam. And now again, here you have a question which has come directly from Williams table. So over here, in Williams 26th edition, page 433, causes of dystocia are given. And if you see in the causes of dystocia, they have specifically mentioned chorioamnionitis, neuraxial analgesia, and higher station at labor onset. So over here, neuraxial block, high fetal station, chorioamnionitis, all of them can lead to uterine dysfunction or dystocia. One over here, I want you to see that nulliparity is associated with uterine dysfunction, but not multiparity, right? So over here, the answer is going to be multiparity. It is nulliparity which is associated with uterine dysfunction. Clear? All are long-term reversible methods of contraception. Long-term reversible methods of contraception, which I always keep on telling you, is the LARC method. This was given in edition 6. It is also given in edition 5. In edition 6, it is given under the heading of miscellaneous points on contraception, right? And there specifically, I have told you what are the long-acting reversible contraceptives. There are 3 contraceptives which come under long-acting reversible contraceptives: IUCDs, implants, and injection DMPA, right? So IUCDs, so over here, levonorgestrel and copper-containing IUCDs, then subcutaneous progestin implants and progestin injections, they come under long-acting reversible contraceptives. Now, for all practical purposes, for all your question purposes, you have to remember that sterilization is a non-reversible or irreversible method of contraception. Although I know that you people know that in certain conditions, we may have to reverse the process of sterilization, female sterilization. We may have to go for a tubal recanalization. But then for all your question purposes, for all your, exam point of view, you have to remember that male and female sterilization are methods of irreversible methods of contraception. This is only under rare circumstances if a female comes to us that we go for tubal recanalization, right? But otherwise, it is taken as irreversible method of contraception. Clear? Now, what is the age group distribution for vulval cancer? Now, these days, vulval cancer has become their hot favorite. And this was one topic which I had predicted that it might come in your exams. And here you have a question on vulval cancer. Question on vulval cancer was present in your session 1 as well as in session 2. In both the sessions, vulval cancer was present. And in my video on vulval cancer, I told you that vulval cancer, the most common age group for vulval cancer is a postmenopausal age group. There are 2 varieties of the most common variety of vulval cancer is squamous cell carcinoma. And in squamous cell carcinoma, you have 2 varieties, warty or the basaloid type and the keratinizing variety. Keratinizing variety is seen between 65 to 70 years of age. It's more common in 65 to 70 years of age. Whereas the basaloid variety is more common, or the warty variety is more common between 55 to 60 years. But by and large, you have to remember that vulval cancer is a cancer of postmenopausal age group, right? So over here, what is the age distribution for vulval cancer? Is it 35 to 55? Is it 45 to 85? Both A and B. I would have marked the answer as 45 to 85 as the correct answer. That is more towards postmenopausal age group, and that is why that is a better option than option A, right? Now, I want all of you to quickly revise vulval cancer with me because that's a very important topic and it can be revised. The beauty of this topic is it can be revised in under 10 minutes. And for that hardly 10 minutes, you leave this topic. So revise this topic with me quickly just now, so that if you are going to give your NEET or if you are going to give INI-CET, you don't have to worry about this topic. So the most common variety of vulval cancer is squamous cell carcinoma. In squamous cell carcinoma, there are two varieties, as I told you. There is a basaloid variety and there is a keratinizing variety. More common one is keratinizing variety, which is also called as the differentiated variety, which is seen in 60% cases, right? So if they ask you which is the most common type of squamous cell carcinoma of vulva, it is the keratinizing variety. Now, amongst keratinizing variety and basaloid variety, keratinizing variety is seen in a little older age group in comparison to basaloid variety, although both of them are seen in postmenopausal females. Just now I told you both of them are seen in postmenopausal females. Both of them are seen in females between 50 to 70 years. But then basaloid variety will be seen in a slightly younger age group, that is 55 to 60 years, whereas the keratinizing variety will be seen in slightly older age group, that is 65 to 70 years, right? So whatever I am telling you about keratinizing variety, the opposite stands good for basaloid variety, right? Now, please remember, keratinizing variety is not related to HPV infection. It is unifocal, and the risk factors for keratinizing variety of squamous cell cancer are lichen sclerosis, chronic inflammatory dermatosis, and a differentiated VIN. Right? Now coming to overall, what are the risk factors for vulval cancer? Overall, the risk factors for vulval cancer are HPV, human papilloma virus infection. HPV infection is not associated with keratinizing. That means it is associated with the basaloid or the variety or the warty variety of cancers. And the most common HPV infection which can lead to vulval cancer is HPV 16. The second most common being HPV 33. Then immunosuppression, that is, patients who have HIV, they have increased risk of vulval cancer. And definitely, just now I didn't say immunosuppression for keratinizing variety. That means immunosuppression is a risk factor for basaloid variety. Cigarette smoking is a risk factor for vulval cancer, the basaloid variety. VIN. Now, VIN can be of two types. It can be a usual type or a differentiated type. If it is a usual type of VIN, it is a risk factor for basaloid variety. If it is a differentiated type of VIN, it is a risk factor for the differentiated variety. That means the keratinizing variety. Then lichen sclerosis and chronic inflammatory dermatosis. These are also risk factors for vulval cancer. And just now I told you these are risk factors for keratinizing variety. You just need to remember that whether it is the keratinizing variety which is more common or the basaloid variety which is more common, which one is unifocal, and what are the risk factors for keratinizing variety, and overall what are the risk factors for vulval cancer. Right? What is the most common presentation of vulval cancer? It's asymptomatic. The most common symptom which you are going to get will be pruritus. Most common site for vulval cancer is labia majora followed by labia minora. Staging of vulval cancer, you have to remember very, very basic things about staging, and I'm going to tell you the FIGO staging. Vulval cancer you have FIGO staging as well as TNM staging. So just remember that stage 1 means that the cancer is limited to the vulva, in which we have stage 1A, 1B. 1A means that the size of the tumor is less than equal to 2 centimeters, or if stromal invasion is less than equal to 1 millimeters. Then comes stage 1B. Now, when stage 1A, because over here the size of the tumor is less than equal to 2 centimeters and stromal invasion is less than equal to 1 millimeters, it is also called as the micro-invasive cancer. Right? Then comes 1B. 1B means either the size of the tumor is more than 2 centimeters or the depth of invasion is more than 1 millimeters. Any of these two things, it is going to come in stage 1B. Right? Then we have stage 2. Stage 2 means any size of the tumor which is involving the lower part of urethra, lower part of vagina, or lower part of anus. Remember, in stage 1 and stage 2, lymph nodes are not involved. The moment your question says lymph nodes are involved, automatically it puts the disease in stage 3 category. So whenever there is lymph node involvement seen, irrespective of the size of the tumor, it comes in stage 3. In stage 4, definitely we are going to deal with metastasis, but other than that, if the lymph nodes are fixed and ulcerated, then it comes under stage 4. Right? So, Now, another very important thing is that for all gynae cancers, stage 4B comes for distant metastasis and if superficial inguinal lymph nodes are involved. So whether it is cancer cervix, whether it is cancer ovary, or whether it is cancer endometrium, whenever the superficial inguinal lymph nodes are involved, you categorize it as stage 4B. Now, in case of vulval cancer, the first lymph nodes which are involved are superficial inguinal lymph nodes, and they are the sentinel lymph nodes for vulval cancer. So, in vulval cancer, stage 4B it is the involvement of pelvic lymph nodes which come under stage 4B, right? So, whereas pelvic lymph nodes are involved in stage 3C, 3C1, right, in endometrial cancer and ovarian in endometrial cancer and cancer cervix. So these are few points which you have to remember. Pelvic lymph node involvement in endometrial cancer and in cancer cervix comes under stage 3C1, right? Pelvic lymph node involvement in vulval cancer comes under stage 4B, right? Inguinal lymph node involvement in endometrial cancer, ovarian cancer, and cancer cervix comes under stage 4B. Clear to all of you? Yes. So these are important points which you have to remember about staging. Now comes management of vulval cancer. Now, if it is a stage 1A vulval cancer, you have to do surgery and lymphadenectomy is not needed because when the size of the tumor is less than 2 centimeters and less than 1 millimeter stromal invasion has happened, then lymph nodes are not involved. So only in stage 1A, there is no need to do any lymphadenectomy. You just have to do surgery for the tumor. And what surgery are you going to do in stage 1A? You are going to do a wide local excision. Wide local excision is also called as simple vulvectomy. So in stage 1A, management is simple vulvectomy and no lymph node dissection. Now, when it comes to stage 1B, and in stage 2. In stage 1B and in stage 2, you have to do surgery plus you have to go for a lymphadenectomy. In case of stage 1B, you can go for lymphadenectomy, you can go for inguinofemoral lymph node dissection or you may go for a sentinel lymph node biopsy. Right? When it comes to stage 3, in stage 3, you have to do surgery along with lymphadenectomy followed by radiotherapy to both the groin and the pelvic areas. Right? So in stage 3 comes the role of radiotherapy where you are going to do surgery, you are going to do lymphadenectomy and you are going to follow it up with radiotherapy. Some of the studies have shown that in stage 3, it is better that you don't do a proper lymph node dissection. You simply do a radiotherapy because if you do lymph node dissection followed by radiotherapy, that leads to increased chances of morbidity. Right? In stage 4, you have to go for chemoradiation followed by surgery if it is needed and if it can be performed. Clear? So this is the broad outline of management for vulval cancer. Now, whenever we are talking about surgical management, as I told you, in stage 1A, you have to do surgical management. 1B, you have to do surgical management. Stage 2, you have to do surgical management. Stage 3, you have to do surgical management. Surgical management consists of treating the tumor, that is one part, and taking care of the lymph nodes, that is the second part. So for the lesion in stage 1A, you are going to do wide local excision. For lymph nodes, nothing in stage 1A. In stage 1B, for the lesion, you are going to do radical partial vulvectomy. Same is the treatment in stage 2. In stage 1B and stage 2, either you can go for partial radical vulvectomy or total radical vulvectomy. And as far as lymph nodes are concerned, you can go for inguinofemoral lymph node dissection, which can be unilateral or which can be bilateral, or you can go for sentinel lymph node biopsy. Right? Now, coming to the management of lymph nodes in general. So, if lymph nodes are palpable, right, then you have to do their biopsy, and if the nodes are positive, you have to remove them followed by radiotherapy. That is what I told you just now. That lymph node positive means, see, lymph nodes palpable means that they are going to come under stage 3. So whenever there is a stage 3 cancer, do a biopsy of the lymph nodes, and if lymph nodes come out to be positive, then you have to remove those lymph nodes followed by radiotherapy. right? And if nodes are negative, they are coming negative on biopsy, then treat them as if they are not palpable. Now, if nodes are not palpable, and if tumor size is less than 2 centimeters and it is less than 1 millimeter deep, just now I told you there is no need for doing any lymph node dissection. But if the size of the tumor is more than equal to 2 centimeters, or if depth is more than equal to 1 millimeters, then you have to do inguinofemoral lymph node dissection. Right? So this is just now what we did, and I have written it in a little different format over here. Now coming to what is the criteria? When are you going to do unilateral lymph node dissection? When are you going to do a bilateral lymph node dissection? See, criteria for unilateral lymph node dissection is if size of the tumor is less than 2 centimeters, number one, there are no palpable nodes, and it should be more than 2 centimeters from the midline. Now, if all these three criteria are fulfilled, then only you are going to go for a unilateral lymph node dissection. I'm repeating, if size of the tumor is less than 2 centimeters, if it is more than equal to 2 centimeters from the midline, and the lymph nodes are not palpable, then only you have to go for a unilateral lymph node dissection. Now, one common query which I keep on getting from you all is that, ma'am, over here in stage 1A, you said that the size of the tumor is less than 2 centimeters and invasion of the tumor is less than equal to 1 millimeters. And just now you said that no lymph node dissection is needed. Right? And now you are saying that you have to do a unilateral lymph node dissection if size of the tumor is less than 2 centimeters. This means that in stage 1B, because size becomes more than 2 centimeters, does it mean that from stage 1B onwards, we have to do a bilateral lymph node dissection? Now, please understand. As I said, in stage 1B, it has to be either of the two. Either the size of the tumor becomes more than 2 centimeters or the depth of invasion becomes more than 1 millimeter. Understand, suppose your question says that there is a tumor which is 1.5 centimeters in size and it is 2 millimeters deep. First tell me, in which stage are you going to put this tumor? Now, although the size of the tumor is less than 2 centimeters, but the depth of invasion becomes more than 1 millimeter. It is 1.5 millimeters, which is given to you in the question. So this means this tumor you are going to put in stage 1B, right? Now, because you are putting it in stage 1B, it means you have to do a lymph node dissection. Right? Now you have to decide whether you have to do a unilateral lymph node dissection or a bilateral lymph node dissection. Now, because the size of the tumor is given as 1.5 centimeters and that means it is less than 2 centimeters, so I am going to go for a unilateral lymph node dissection. So have you understood that in stage 1B also you can go for a unilateral lymph node dissection if the size of the tumor is less than 2 centimeters, right? Depth of the invasion has nothing to do with lymph node dissection. Right? The criteria for unilateral lymph node dissection is size should be less than 2 centimeters, the nodes should not be palpable, and it should be more than equal to 2 centimeters away from midline. If any of these criteria are not being fulfilled, you are going to go for bilateral inguinofemoral lymph node dissection. So previously, there was a question which was given in your INI-CET, and the question said that there is a vulval cancer where the size of the tumor was 2 into 3 centimeters. Now, the moment they say that the size of the tumor is 2 into 3 centimeters, I know that I am putting it in stage 1B. And if I am putting it in stage 1B, I have to do a partial radical vulvectomy or a total radical vulvectomy, right? And that also means I have to do a lymph node dissection. Now, because the size of the tumor is given 2 into 3 centimeters, right? This means I cannot perform unilateral lymph node dissection. I will have to go for a bilateral inguinofemoral lymph node dissection. Clear to all of you? Yes. Now, this is just one thing which I have not taught to you, and I want you to remember this. Criteria for sentinel lymph node biopsy. So, the criteria for doing sentinel lymph node biopsy is that the size of the tumor should be less than 4 centimeters. It should be more than 1 millimeter deep. There should be no palpable node, and it should be a unifocal disease. If all these criteria are being fulfilled, then you go for a sentinel lymph node biopsy. So for sentinel lymph node biopsy, the size of the tumor is less than 4 centimeters. For unilateral lymph node dissection, the size of the tumor is less than 2 centimeters. Sentinel lymph node biopsy in vulval cancer is done using isosulfan blue dye. Clear? So now from next time onwards, whenever you have to revise vulval cancer, so just open this video on your YouTube and revise vulval cancer with me. Clear? Then comes a question which was very easy again, and from your notes, a woman with eclampsia is started on magnesium sulfate. What is the first sign of magnesium sulfate toxicity? I told you, bacho, that in INI-CET also there was a question on magnesium sulfate, and there were 3 questions on PIH. In NEET 2021, in NEET 2022 also there were questions on PIH. So PIH is a very, very important topic for your upcoming any exam, whether you are an FMG aspirant, whether you are a NEET PG aspirant or an INI-CET aspirant. PIH, everything about PIH is very, very important to you. Now, this is a very easy question, and I'm sure all of you know that the first sign of magnesium sulfate toxicity is loss of knee jerk. Again, this was given by me in the main videos, in the revision videos, and also I had discussed this question in INI-CET May 2022 recall. There I had told you that magnesium sulfate is not an antihypertensive, it's an anticonvulsant drug. Please do not say that it is an antihypertensive. It is centrally acting, and magnesium sulfate has a very low therapeutic range between 4 to 7 milliequivalents per liter, which is equal to 2 to 3.5 millimoles per liter or 4.8 to 8.4 milligrams per dl. The first sign of magnesium sulfate toxicity is loss of knee jerk, which happens when magnesium concentration is more than 10 milliequivalents per liter, roughly around 12 milliequivalents per liter. Decreased respiratory rate is a sign of magnesium sulfate toxicity. Ultimately, when magnesium concentration becomes more than 12, it leads to respiratory paralysis and respiratory arrest. The other symptoms are diaphoresis, slurring of speech, and flushing. Cardiac conduction defects are seen when magnesium concentration becomes more than 15 milliequivalents per liter. Oliguria is not a sign of magnesium sulfate toxicity. Right? It is not a sign of magnesium sulfate toxicity. This is also something which I have told you. Management of magnesium sulfate toxicity is calcium gluconate 1 gram IV. Right? So over here, the answer is loss of knee jerk. Coming to the next question, daughter of a woman who received DS during pregnancy is at higher risk for. So if you remember in the video on uterine malformations or Mullerian malformations, I had told you that diethylstilbestrol is an estrogen derivative which was earlier being used was being given to pregnant females, but then it was withdrawn from the market because it was seen that when DES was given to a pregnant female, it led to problems in the male as well as female fetuses. In female fetuses, it leads to T-shaped uterus, it leads to clear cell cancers of vagina and cervix, vaginal adenosis, corkscrew cervix, genitourinary malformations, and fallopian tube abnormalities like absent fimbria. Right? So over here, the answer is clear cell carcinoma. Now, these females who received DS in their intrauterine life, when they grew up, it led to early menopause and there was increased chances of breast cancer. Now, males who were exposed to DS, it leads to increased incidence of cryptorchidism, testicular hypoplasia, hypospadias, and microphallus. Now, a very important thing was, which I had also told you in the videos, that earlier studies showed that when DS was given to a pregnant female, in the female fetuses, it did not lead to any renal anomalies, but in male fetuses, it led to any renal anomalies. But when further studies were done, this was not substantiated, this was not proven. And so later on, they said that DS exposure can lead to renal anomalies in the female fetus also. And that is why I have written genitourinary malformation in the female fetus as well. Sometimes you get a question from the previous Q bank And if the question is picked up from the previous Q bank, the question may say all of the following abnormalities are seen in a female fetus exposed to DES except. In that question, because that was picked up from a previous Q bank, the answer would be renal anomalies. But now the studies have shown that renal anomalies can be seen in a female fetus who was exposed to DES. So remember both these things. Clear? Okay. Coming to the next question, which again is a very easy one. According to new WHO guidelines, what is the minimum number of antenatal visits recommended to have a positive pregnancy outcome? So all of you know that the minimum which is advised by Government of India is 4. Minimum which is advised by WHO is 8. Ideal number of visits are 12 to 18. Till 28 weeks, it has to be 1 visit in every 4 weeks. Between 28 to 36 weeks, it has to be 1 visit in 2 weeks. Beyond 36 weeks, it has to be 1 visit in every week. Now, this is a screenshot from the revision videos which I have given to you in OBS in edition 6. The same thing is also there in the video on antenatal care, right? Then steps of DNC. Now again, this was highly predictable that they are going to ask you steps of DNC, and this was the reason why in edition 6, I had told you not only the steps of DNC, I had also told you the steps for suction evacuation in the video on MTP. So please remember that this again has become a trend for INI-CET, that they keep on asking you steps of certain important surgeries. So in the session which I had taken just before INI-CET with Dr. Abbas, I told you there are 4 procedures whose steps you are going to revise. Number 1, cesarean section. Number 2, hysterectomy. Number 3, DNC and suction evacuation. And number 4, episiotomy. Right? So these are very, very important things. And here you have a question on the steps of DNC. So whenever you are performing DNC, the first step which you have to do is you have to assess the size of the uterus and the direction of the uterus, which is done using a uterine sound. Right? Then you have to dilate the os, and the dilation of the os will be done using Hagar's dilators. So first step is step 4, then you have step 3, then you have step 1, and then you are going to go for a curettage. 4, 3, 1 and 2, and that means option A is the correct answer. Over here is a curette. This is a blunt and a sharp curette. I have also told you so many times that in a pregnant uterus, normally we use a blunt curette, except for one condition, and that exception is once you have done evacuation for a molar pregnancy. So once you have evacuated a mole, then it has to be followed by a sharp curette, right? What is false regarding late decelerations? Again, something which we have done in our main videos, that is the antepartum fetal surveillance. In that video, we have covered it. So I have told you that late decelerations are the ones which are going to be gradual, right? And they are going to be smooth. So this is late deceleration. It is going to be gradual. It is going to take more than equal to 30 seconds. It is going to be a very smooth curve which you are going to get. Decelerations in general are defined as a dip in fetal heart rate by 15 beats per minute for 15 seconds. So over here, this statement, that is a deceleration is defined as 10 beats per minute 2 times in a 20-minute period, is wrong. It has to be 15 beats per minute for 15 seconds. That is what is a deceleration defined as. Late decelerations are smooth and gradual. Yes, late decelerations are the most ominous type of decelerations which you can get. And as the name suggests, late decelerations are going to start after the onset of uterine contraction. So till the uterine contraction reaches its peak, till that time, the dip in fetal heart rate doesn't begin. Right? Once the uterine contraction reaches its peak, then the dip in fetal heart rate begins, and once the uterine contraction ends, the dip doesn't end. Dip is going to end later than the uterine contraction. That is why it is called as a late deceleration, right? So, Over here, it starts after the uterine contraction ends and ends after the uterine contraction ends. Yes. So it starts after the uterine contraction begins and it ends after the uterine contraction ends. That's a true statement. It is not associated with accelerations. That's also true. So over here, the false statement was option A. Where do you get a late deceleration? You get a late deceleration in case of uteroplacental insufficiency. I had also shown you this CTG graph over here, and I had also told you that in CTG, how do I come to know this is a CTG graph? Because I'm going to see two graphs. I'm going to see a graph of fetal heart rate and I'm going to see a graph of uterine contractions, right? In an NST graph, you get only fetal heart rate. You don't get any uterine contraction. So this over here is a CTG graph. In this CTG graph, you can see this is the uterine contraction. When the uterine contraction began, the dip did not begin. When the uterine contraction was at its peak, at that time, the dip in fetal heart rate started. And when the uterine contraction ended, the dip did not end. The dip ended later than the uterine contractions. Now, whenever you are getting a late deceleration, the things which you have to do are you have to go for intrauterine resuscitation, which means you have to put your patient in left lateral position. You have to give her IV fluids, you have to give her oxygen, and you have to stop any uterotonic drug which you are giving. Now, all these things are going to increase the placental perfusion, and by doing this, if the deceleration subsides, then it's good. But if deceleration persists in spite of doing this, then that's an indication for doing cesarean section. So remember that all CTG tracings are divided into three categories, and I want you to remember only category 1 and category 3. Category 1 stands for a normal CTG tracing. A normal CTG tracing will have fetal heart rate between 110 to 160 beats per minute. Fetal heart rate is going to show a beat-to-beat variability of 5 to 25 beats per minute. That's very, very important. There shouldn't be any late decelerations. There shouldn't be any variable decelerations. Early decelerations may or may not be present. Accelerations may or may not be present. If these criteria are fulfilled, then your graph belongs to CTG1 tracing, which is an absolutely normal tracing. Right? Now, if in the CTG graph, you are getting absent fetal heart rate variability, that means it is a fixed fetal heart rate is not changing, but along with that, you are getting either bradycardia or persistent late decelerations or persistent variable deceleration. Then that comes under category 3 stage tracing. Or if you are getting a sinusoidal heart rate pattern, that means on a CTG graph, you are getting a wave pattern like this. Normally, this is how you get a fetal heart rate. But if you are getting a wave pattern, if you are getting a wave-like pattern, which I showed you just now, that is called as a sinusoidal heart rate pattern. A sinusoidal heart rate pattern indicates fetal anemia and hypoxia. And that is why whenever you get a sinusoidal heart rate pattern, that also comes under category 3 CTG findings. What is the significance for category 3 CTG findings? Category 3 CTG finding means that whenever you get a finding like this, you have to prepare the patient for immediate cesarean section. And in the meanwhile, while you are preparing for cesarean section, you are going to take the steps for uterine resuscitation. That means you are going to stop any uterotonic drug, you are going to give oxygen, you are going to give IV fluids, and you are going to turn your patient in left lateral position. But management, definitive management for a category 3 CTG finding is immediate cesarean section. Clear? Not a component of biophysical profile. Again, a question on biophysical profile was asked in INI-CET May 2022. And all of you know that I have taught you the mnemonic TB meningitis, always notorious for the components of biophysical score, where T stands for fetal tone, B for fetal breathing movements, M for gross body movements, A for amniotic fluid, that is single largest vertical pocket, and N for NST. Right? And this NST has to be done for a period ranging between 20 to 40 minutes. right? Now, amniotic fluid volume, yes. Fetal tone, yes. NST, yes. DFMC is not a component of biophysical score. To each of these points, to each of these parameters, you have to give a score of 2 or you have to give a score of 0. And this is a slide which I have taken from INI-CET May 2022 recall. I know that all of you know the parameters for biophysical score. What I want you to keep in mind for the upcoming INI-CET exam is the score and the management. So remember, if biophysical score is 10 by 10 or 8 by 10, but 8 by 10 is in 8 by 10 score, the amniotic fluid volume is normal, then that's a normal biophysical score and it should be repeated every weekly. Now, if you are getting a score of 6 by 10, but amniotic fluid volume is normal, right? In that case, you have to look at, that's an equivocal result, and you have to look at the gestational age. If gestational age is more than equal to 37 weeks, you have to deliver. If gestational age is less than 37 weeks, you have to repeat the test in 24 hours. Now, if you are getting a score of 8 by 10 or 6 by 10, and on ultrasound, you can see that the amniotic fluid volume is less. That means the single largest vertical pocket is less than 2 centimeters. Then you have to deliver the fetus at more than equal to 36 weeks. Please remember, this is newly updated from Williams. So whatever I am telling you over here, this is what you have to follow. Right? If score is 4 by 10, you have to deliver your patient at more than equal to 32 weeks. And if score is 2 by 10 or 0 by 10, you have to deliver the patient immediately. Then please remember that biophysical score to some extent gives you an idea of the pH of the fetus. If you are getting a normal biophysical score of 8 or 10, that means it is associated with the normal pH of the fetus. If score is 0, 2 or 4, that is associated with fetal acidemia. And if a score is 6, then that is equivocal result. Right? Why I'm stressing on this point is because this was a question which you had got in INI-CET May 2022. And over here it was said all are true about biophysical profile except it includes breathing, movement, tone and amniotic fluid volume. Yes. It can tell us about fetal outcome and fetal pH. Yes. Score is inconsistent with fetal pH. No, it is not inconsistent with fetal pH. A score of less than 4, pH of less than 7.2, score of 0, 100% fetal acidemia. Yes, right? So remember that biophysical score is a very, very important topic for all. Rather, I would say antepartum fetal monitoring is very, very important for any of your upcoming exams. What is a modified biophysical score? In modified biophysical score, there are only 2 parameters which you look at. Number 1 is NST and the number 2 is amniotic fluid index. Remember, modified biophysical score is a screening test, whereas biophysical score or a Manning score is a diagnostic test, right? Wrong statement regarding period of gestation calculation. Again, this is something which we have done in lot of detail in the video on antenatal care and also in revision videos. In revision videos also, I have told you how to calculate EDD. Very, very important. So over here, I have told the questions which was given was wrong statement regarding period of gestation calculation. It is calculated from last day of menstrual cycle. No, please remember that POG or EDD is calculated from first day of the menstrual cycle. That's number 1 rule, right? Number 2 rule is that whenever you are calculating the POG or whether you are calculating the EDD using Negley's formula, you presume that the cycles of the female were 28 days and they were regular, right? Now, suppose if cycles of the female are, not regular. Right? So if the question says that the cycle of the female is not regular, or if your question says she was using oral combined pills, or if your question says she was not and she was lactating. So if your question is saying any of these 3 things, that the cycles are irregular, cycles of the patient prior to conception were irregular, or female was on OCPs when she had conceived, or if female was lactating when she has conceived, or female doesn't remember her LMP. In these cases, the best method for calculating period of gestation is ultrasound using crown rump length, right? Then the other thing is, which I want you to tell, is for IVF conceptions. For IVF conception, you have to remember that in IVF conception, that could be a fresh cycle or it could be a frozen cycle. In a fresh cycle, the day of oocyte retrieval is equal to the day of fertilization. In other words, the day of oocyte retrieval is day 14 of the cycle, and all of you know that the total duration of pregnancy is 280 days. So if I want to calculate EDD, I would be given the day of oocyte retrieval. To that, I have to add 266 days to get the EDD, right? If it is a frozen cycle, in a frozen cycle, the day of oocyte retrieval is not the same as day of fertilization. In that case, you have to focus upon the day of embryo transfer. Embryo transfer can be done on day 3 or day 5. Day 3 means day 17 of the cycle, right? So, and day 5 means day 19 of the cycle, right? So, for day 3 transfers, you have to add 263 days because 17 plus 263 is 280. So if you are given day 3 transfer, you will have to add 263 to get EDD. And if you are given day 5 transfer, you will have to add 261 to get the EDD. Because day 5 transfer means you are transferring on day 19 of the cycle. Day 3 means 3 days after the day of fertilization. So fertilization happens on day 14. 3 days after that means day 17. And 5 days after that means day 19. So for IVF cycles, just remember a simple thing. If it is a fresh cycle, you have to add 266 days to the day of egg retrieval. If it is a frozen cycle, for day 3, you have to add 263 days. For day 5, you have to add 261 days. Clear to all of you? First trimester ultrasound is best assessment? Yes. If you have to calculate period of gestation and you have to do it based on ultrasound, the earlier you do the ultrasound, the more accurately it tells you about the gestational age. Again, this is a point which we have covered in OBS radio integration, as well as where I have done antenatal patient's history with you. In an IVF cycle, day of embryo transfer or day of fertilization is needed to calculate POG? Yes. Crown rump length is the best measure in the first trimester? Yes. In the first trimester, the best parameter to calculate period of gestation is crown rump length, right? In second trimester, it is biparietal diameter. If biparietal diameter is not given, then the second best answer is head circumference. In third trimester, ideally, you should use a combination of parameters. But if you have to pick up a single best parameter, then it is femur length, right? So let's see over here, second session. A 16-year-old patient presents with absent menses. So she is a case of primary amenorrhea. And this patient has widely spaced nipples, webbed neck, right? Tanner grade 1 breast development, and ultrasound shows streak ovaries. Now, so much is given that the diagnosis becomes very clear that this is a clear-cut case of Turner's syndrome. In Turner's syndrome, karyotype is 45XO, and all of you know that both the X chromosomes are needed for proper development of ovary, and that is why in Turner's syndrome you have got streak gonads. Right? And because the gonads are streaked, that is why there is decreased estrogen. And because there is decreased estrogen, the negative feedback on LH and FSH is gone. So the levels of LH and FSH are high in case of Turner's syndrome. Because there is decreased estrogen, so for a breast development, the hormone which is needed is estrogen. So there is going to be absent breast development. In other words, grade 1 breast development, right? And you all know that the additional features for Turner's syndrome are webbing of neck, shield-shaped chest. Then they have got cardiac abnormalities, the most common one being bicuspid aortic valve followed by coarctation of aorta. They have increased chances of all these autoimmune diseases like Hashimoto's thyroiditis and diabetes. Right? Now, in the main videos also, I have given you how to differentiate between Turner's syndrome, Swyer's syndrome, Kalman syndrome, and cryptomenorrhea, because in all these 4 conditions, a female is going to present to you with primary amenorrhea, but uterus is going to be present. Right? So the differential diagnosis of primary amenorrhea with uterus present are Turner syndrome, Swyer syndrome, Kalman, and cryptomenoria. And in this table, I have told you everything what you need to know about Turner syndrome, Swyer syndrome, Kalman syndrome, and cryptomenoria. Same thing I have also repeated for you in the revision videos. In revision videos, again, I have repeated this table. So I am pretty sure that you know the answer to this question, and that is Turner syndrome. In Kalman syndrome, you never get streak ovaries. In Kalman syndrome, the problem is the ovaries are absolutely normal. Ovaries will be normal. But the problem is that the GnRH releasing neurons, they fail to migrate from olfactory placode into the hypothalamus. So there is going to be a hypothalamic failure, right? Then in androgen insensitivity syndrome, you get proper breast development corresponding to Tanner stage 4 or 5, right? That is why it is not a case of androgen insensitivity syndrome. Similarly, in Mayer-Rokitansky-Kuster-Hauser syndrome, which is absence of both the Mullerian ducts, in Mayer-Rokitansky-Kuster-Hauser syndrome also there will be proper breast development, right? And in both these conditions, you are not going to get streak ovaries. In androgen insensitivity syndrome, the gonads are going to be testes, right? Whereas in Mayer-Rokitansky-Kuster-Hauser syndrome, gonads are going to be ovaries. And ovaries will be normal and properly functioning. Why? Because ovaries develop from genital ridge. They have nothing to do with your Mullerian duct, right? So the answer over here is Turner syndrome. Coming to the next question, under the Anemia Mukt Bharat program, mild to moderate anemia is treated using. Now, over here, again, in your main videos and in your revision videos, I had told you that for treatment of anemia in pregnancy, you divide your patients into two categories. Number one is females who have got pregnant females who have mild to moderate anemia and females who have severe anemia. Severe anemia means hemoglobin less than 7. For mild to moderate anemia, you have to look at the gestational age. If gestational age is less than 34 weeks, you have to give oral iron and folic acid tablets. Now, the tablets which you have to give are 2 tablets per day, right? And then you have to look at the compliance of the patient. You are going to check her hemoglobin after at least 3 weeks, because the increase in hemoglobin after taking oral iron occurs after 3 weeks. So at least 3 weeks, and the recommended is 1 month. So after 1 month, I'm going to check her hemoglobin, and if her hemoglobin doesn't increase, then either she's a case of refractory anemia or she has been non-compliant. If she has been non-compliant, in that case, I'm going to switch her to the parenteral iron, because for parenteral iron, I am going to give the iron. I don't need compliance of the patient, right? Remember, whether it is parenteral iron, and the parenteral iron which you have to give, the most commonly used is iron sucrose. But the best one is ferric carboxymaltose. Ferric carboxymaltose is expensive, and that is why it is the best, but it is not the most commonly used, right? Now, remember that for parenteral iron, the rate of increase of hemoglobin is similar to oral iron, right? The only difference is in parenteral iron, I am going to give it. So patient's compliance is not needed, right? So let us go and see, under Anemia Mukt Bharat program, mild to moderate anemia is treated using iron and folic acid tablets, 3 tablets OD. No, it is 2 tablets OD. Iron and folic acid tablets and IV sucrose. IV sucrose over here means IV ferric sucrose. Remember, oral iron and parenteral iron are never given together, right? IV sucrose for non-compliance with oral tablets, yes. IM ferric carboxymaltose, no. So you are going to give IV sucrose for non-compliance with oral tablets. Initially, if the gestational age is less than 34 weeks, you have to start with oral iron, and if patient, and that too 2 tablets a day. And if the patient is non-compliant, then you are going to shift her to IV iron sucrose, the parenteral iron. Clear to all of you? Yes? Now, all of the following are risk factors for vulval cancer. As I told you in session 2, there was a question on vulval cancer, and this was the question on vulval cancer. So all of the following are risk factors for vulval cancer except, so since I have told you everything about vulval cancer, let's do this question directly. Vulval dystrophy, yes. Smoking, yes. Vulval warts, yes. Vulval hematomas, no. And again, this is a screenshot from vulval cancer where I had discussed with you the risk factors for vulval cancer. The non-contraceptive uses of oral contraceptive pill includes all except. Again, non-contraceptive benefits of OCPs I have taught you in detail in the video on contraception, and I told you that oral combined pills, they decrease the risk of endometrial cancer, they decrease the risk of ovarian cancer, ovarian cyst, benign breast diseases and colorectal cancer, whereas they increase the risk of hepatic adenomas, breast cancer, especially in premenopausal females, the chances are slightly increased, and cancer cervix. They have no effect on liver cancer. Other than that, OCPs make cycles regular, and that is why they are the drug of choice for irregular cycles. They are the drug of choice in PCOS patients for irregular cycles. OCPs decrease menstrual blood loss, and that is why they are used in conditions of atypical uterine bleeding like fibroid and endometriosis. OCPs make the cycle anovulatory, and that is why they are used in pelvic pain disorders like primary dysmenorrhea and endometriosis. They are used for managing ovarian cysts and menstrual migraine and Michel-Merz disease. OCPs are also used for managing premenstrual syndrome. Also, they are not the drug of choice. The drug of choice are SSRIs. Right? OCPs, and PID, that's very important. See, the studies are very controversial. Some of the studies say that they increase the risk of PID. Some of the studies say they decrease the risk of PID. Overall, the studies are inconclusive whether they increase or decrease the risk of PID. But if they ask you which is the most common PID which is associated with OCPs, the answer is chlamydia. Definitely the chances of chlamydia are increased with OCPs, and the most common vaginitis which occurs with OCP use, that is candidiasis. So they protect against STDs including HIV, that's wrong. They reduce the risk of ovarian cancer, yes. They reduce the risk of ectopic pregnancy. Please remember that the absolute risk of ectopic pregnancy is decreased with all contraceptive methods. Contraceptive methods, they decrease not only the chances of intrauterine pregnancy but ectopic pregnancy also. They decrease the risk of endometrial cancer? Yes. So the answer over here is option A. Coming to the next question, a woman with 35 weeks plus 5 weeks gestation complains of epigastric pain, headache and blurring of vision. Her heart rate, that could be anything, which we don't know what they had given the heart rate as. BP 170 by 110. She is in labor pain. Examination shows 3 centimeters dilatation. Bag of liquor is present. What is the management? Now, first tell me what is your diagnosis. So over here, her BP is increased. She is a case of severe pre-eclampsia because her BP is 170 by 110. The moment BP becomes more than equal to 160 by 110, that is severe pre-eclampsia. And because patient has come to you with epigastric pain, blurring of vision and headache, that means she is a case of impending eclampsia. So she is severe pre-eclampsia with impending eclampsia, right? And whenever you have a case of severe preeclampsia with impending eclampsia, how are you going to manage? See, because she is a case of severe preeclampsia, you have to give her a drug to control her convulsions, and the drug of choice becomes magnesium sulfate, number 1. Number 2, you have to give her antihypertensives to decrease the risk of intracranial hemorrhage. So I have to give her antihypertensives. Rather, if BP is more than 160 by 110, that comes under the category of hypertensive crisis. So I have to give her IV antihypertensives, the drug of choice being any one of the 3, either IV labetalol or IV hydralazine or oral nifedipine. Right? So out of these 3 drugs, I'm going to give any drug. So number 1, I am going to give her magnesium sulfate to control her convulsions, to prevent her convulsions, sorry. This is to prevent her convulsions. Number 2, I am going to give her antihypertensive. And number 3, I am going to go for immediate termination of pregnancy. Right? So in case of impending eclampsia, you have to terminate pregnancy immediately. So option A, conservative management, no. Option B, administer tocolytics and deliver at 37 weeks? No. Option C, treat hypertension, administer magnesium sulfate and consider termination of pregnancy? Yes. Give steroid cover? No. We are not going to do that. Now, I can give her 1 dose of corticosteroid, right? And I will give her 1 dose of corticosteroid and immediately I'm going to take her up for termination of pregnancy. I am not going to wait for 48 hours for the effect of corticosteroid to come. Impending eclampsia means immediate termination of pregnancy. Clear to all of you? And again, in the revision videos and in main videos, I have covered this in detail, right? Then placenta previa is going to show you dark, painful bleeding. All of you know that in placenta previa, bleeding is fresh, so it has to be a red bleeding, and placenta previa is a painless condition, so this is wrong. Uterine tenderness is present? No. There is increased uterine size? No. Increased uterine size is seen in abruptio because of the concealed variety of abruptio. In case of placenta previa, the size of the uterus is equal to the period of gestation. Warning bleeds? Yes. In case of placenta previa, you get warning hemorrhage. Warning hemorrhage means that initially the bleeding is going to be less and later on it is followed by torrential bleeding. And over here again, I have attached screenshots from the videos of antepartum hemorrhage where I have told you about each of these points very, very clearly, right? So, again, in revision videos also, I have taken up placenta previa, abruptio, vasa previa and preterm labor, which is a differential diagnosis of bleeding in 3rd trimester. Here also I have told you in placenta previa, bleeding is painless, it is causeless, it is recurrent, warning hemorrhage is present and there is bright red color of blood, fetal heart sounds are normal. On per abdominal examination, uterus is soft, relaxed and height of uterus is equal to period of gestation. Per speculum and per vaginal examination are contraindicated and apt test is negative. Apt test is positive in case of vasa previa, right? So that was again a very easy question. APH due to abruptio shows, and this was a multiple choice, right? So uterine tenderness, yes, that is present in case of abruptio. In abruptio, uterus is tense and tender. And why is it tense and tender? This is because when the placenta detaches, it releases thromboplastin, and thromboplastin is a uterotonic agent which increases the basal tone of the uterus, and that makes the uterus tensed and tender, right? So you are going to get a firm uterus. Yes, the size of the uterus will be increased. Yes, the size of the uterus is more than the period of gestation. This is because of concealed hemorrhage. Painless vaginal bleeding is a feature of placenta previa. It's not a feature of abruptio. Then there was an image, I don't know the image, but whatever we have, questions we have got, they said, the students said that there was tuft of hair present. It was an ovarian mass with a tuft of hair. And I'm sure if you are getting an ovarian mass with a tuft of hair, you know that it is a dermoid cyst, that is a mature cystic teratoma. Everything about mature cystic teratoma I have covered in the videos for you, whether it is revision videos or whether it is the main videos, right? So it is going to be a mature cystic teratoma. If you can see over here, whenever you get an ovarian mass where you get a teeth or tuft of hair, that means it is an image of a dermoid cyst. Generally, these teeth and hair, they appear from a raised area which is called as Rokitansky protuberance, and on ultrasound you can see this Rokitansky protuberance, right? Remember, dermoid cyst is the most common ovarian tumor which is seen in reproductive age females. It is the most common ovarian tumor in a pregnant female. Generally, dermoid cyst is unilateral, but in 10% cases it can be bilateral, and that's a question which is asked. It has all 3 components of germ cell layers, but the most important component which is it has got is ectodermal. Although dermoid cyst is benign, the risk of malignancy in dermoid cyst is 0.2% to 2%, right? And again, that percentage is very, very important. And the most common malignancy which can occur in a dermoid cyst is squamous cell carcinoma, most common site being Rokitansky protuberance, right? On ultrasound, in case of dermoid cyst, generally because it is a cystic swelling, you are going to get the entire swelling as a black area, as an anechoic area. But at one side, you are going to see a white area, and that is what is Rokitansky protuberance, right? So coming to the next question, a woman presents at 8 weeks of gestation. Which of the following signs can be elicited at this gestation? So all of you know that in first trimester, that is the signs of early pregnancy are number 1, Goodell sign. Goodell sign is softening of the cervix, which is seen earliest, and that is seen by 6 weeks of pregnancy. Then you get Chadwick sign or Jackmere sign, which is bluish discoloration of the vagina. Then you get Osiander's sign, which is pulsations in the lateral fornix of the vagina. Now, Chadwick sign and Osiander's sign are seen by 8 weeks of pregnancy. Other than that, the signs which you get in first trimester are Hagar signs and Palmer sign. In Palmer sign, you get regular rhythmic contractions of the uterus. In Hagar sign, when you do a bimanual palpation with your one hand inside vagina, one hand behind the uterus perabdominally, both the fingers of your vaginal and abdominal hand, they seem to touch each other. So these are the signs of early pregnancy. Hagar sign is seen between 6 to 10 weeks. Goodell sign is seen at 6 weeks, at and beyond 6 weeks. All the other signs, they become positive by 8 weeks, right? So in third trimester and second trimester, the signs which you get, internal ballottement is a sign which you get in second trimester by 16 weeks. Internal ballottement means that when you do a per-vaginal examination and when you push the presenting part up, again it comes down and touches your finger. Right? External ballottement is seen by 18 to 20 weeks. So by 20 weeks, 18 to 20 weeks, external ballotment is seen. Quickening is the perception of first fetal movement by the mother. So whenever mother feels first fetal movement, that is what is called as quickening. And quickening is again a sign of second trimester. Braxton Hicks contractions, they are non-painful, irregular uterine contractions which are happening throughout pregnancy, and they are seen around 16 weeks. They begin around 16 weeks of pregnancy. So internal ballotment, external ballotment, quickening, and Braxton Hicks contractions are signs of second trimester. Signs which you get in third trimester are frequency of micturition. So frequency of micturition was a thing which you were getting in first trimester also, because the uterus enlarges, it rubs against the bladder, so you get increased frequency of micturition in a pregnant female, and this increased frequency of micturition returns back as a symptom in third trimester. This is because now the fetal head enters into the pelvis, and that irritates the bladder, and that leads to increased frequency of micturition. Another sign which you get in third trimester is lightening, which is relief from respiratory discomfort. All of you know that at 36 weeks of pregnancy, the height of the uterus corresponds to Zivi sternum. Right? And at that time, mother experiences a lot of respiratory discomfort. Now, after 36 weeks, the head of the fetus goes down into the pelvis. So after 36 weeks, the fundal height decreases. And because fundal height decreases, mother is relieved from the respiratory discomfort which she was happening. And that is what is called as lightening, which is also called as welcome sign. Right? So, Goodell sign, yes, it is seen at 8 weeks. Osiander sign is seen at 8 weeks. Internal ballotment is a sign of second trimester, and lightening is a sign of third trimester. So the answer over here, the combination would be a combination of A and B, right? So this was a multiple choice question which was given to you. Next, consider the following actions under active management of third stage of labor and arrange them in right order. And I don't think so I need to explain this question anymore to you. Active management of third stage of labor. Repeatedly, I have been explaining this in the main videos and in the revision videos. So the first step is you have to exclude the presence definitely of another fetus, and you have to give injection uterotonic. Deliberately, I have arranged them in this correct sequence so that you can remember it in this order only. So you have to give injection uterotonic after the delivery of the baby or after the delivery of the anterior shoulder. Then you go for delayed cord clamping. Then you deliver the placenta by controlled cord traction, which is also called as modified Brand-Andrews technique. And the last step, or the fourth step, is intermittent assessment of uterine tone. Earlier, this step was uterine massage. So it is A, B, C, and D. Clear to all of you? Please remember, delayed cord clamping is included in active management of third stage of labor. Early cord clamping is not included in active management of third stage of labor. Earlier, it was uterine massage. Now, uterine massage has been replaced by intermittent assessment of uterine tone. Clear? So everything about active management of third stage of labor has been covered in detail for you. Now, what can be said about a graph? A graph was given where the students are telling me that only fetal heart rate was given, uterine contractions was not given. And just now I told you, if you are getting a graph where only fetal heart rate is given, uterine contractions are not given, then that is an NST graph, right? So if you are getting only fetal heart rate, that is NST graph. If you are getting a graph where there is fetal heart rate and there are uterine contractions, that is a CTG graph. So over here, if you can see, you are getting only fetal heart rate. That means it is an NST graph. Over here, you can get fetal heart rate and you are seeing uterine contractions. That is a CTG graph, right? Then there was an image which was showing marginal cord and also a separated lobe. So if you are getting marginal cord insertion and if you are getting a separated lobe, that means it is marginal insertion of the cord as well as a circumfuriate lobe. And all these images I've already discussed with you. Over here, this is an image where you can see that there is a big placenta which is separated and a small part of the placenta has separated from it, but it remains connected by blood vessels. This is an image of circumfuriate lobe, right? And this over here is normally how the cord is inserted. Normally the cord is inserted on the fetal side in the center. But if the cord is inserted along the margins, that is marginal insertion of the cord, and that is also what is called as a battledore placenta. Right? Please remember that it is very important for you to look at these images of circumfuriate lobe, of placenta bilobata, velamentous insertion of the cord, and for battledore placenta. These are 4 very, very important images which you should know. Hormone secreted by placenta, that's very easy question. All of you know that HCG is secreted by placenta, FSH and LH are secreted by anterior pituitary, and GnRH is secreted by hypothalamus. Perimortem cesarean section is done in. Now, I have told you in detail that whenever you are doing cesarean section, depending upon the uterus, where you are giving the incision on the uterus, you classify the cesarean section. If you are giving incision on the upper segment of the uterus, which is a vertical incision, it is called as classical cesarean section. And this incision is called as Sanger's incision. Right? The problem with the classical cesarean section is that bleeding is more, the repair is difficult, healing is not very good, and the risk of rupture in subsequent pregnancies are 4 to 9%. And this is the reason why classical cesarean sections are no longer done. Now, if you are giving an incision in the lower segment, and that too a transverse incision, this incision is called as Kerr incision, and this is what is a lower segment cesarean section, and this is the most commonly done. Now, in case of lower segment cesarean section, this is the most commonly done cesarean section because the chances of rupture are very, very less with this kind of cesarean section. Now, in lower segment, if you are giving a vertical incision, that is what is called as a chronic incision. Right? And again, a chronic incision may, next time when a patient is going to conceive, you are not going to go for VBAC. You are going to go for vaginal delivery after cesarean section only if an LSCS was done and a Kerr incision was given. In case of classical cesarean section and in case of chronic incision, you never go for vaginal delivery after cesarean section because the chances of rupture with classical cesarean section are 4 to 9%, whereas with chronic incision, it is 1 to 7%. So VBAC cannot be tried in this case, right? Now, under very rare circumstances, we are doing classical cesarean section these days, and that is being done when the lower segment cannot be approached either due to dense adhesions or due to severely contracted pelvis or cancer cervix, or if it is a placenta previa and a morbidly adherent placenta where the placenta is stuck onto the lower segment, right? Or if the lower segment is not formed and it is a very, very early preterm section, or sometimes, in case of transverse lie of the fetus, that is very rare. One more indication which I didn't write over here, but I told you that if you are doing a perimortem cesarean section, a perimortem cesarean section is done whenever a pregnant female is having cardiac arrest. And within 5 minutes, you have to deliver the baby. Within 5 minutes, you have to deliver the fetus, and irrespective of the fact that whether, anyone is available or not, You are not going to shift to your patient to OT in the emergency room only. You are going to do the cesarean section, and you are going to do a classical cesarean section. You are going to give a vertical incision on the skin, and immediately you are also going to give a vertical incision on the uterus, right? And you are going to deliver the fetus. So this is again and only amongst one of the few indications for classical cesarean section. So a perimortem cesarean section is done, upper segment cesarean section, it is not done in OT, it is done in emergency, right? Vagitus utrinus. Now, vagitus utrinus, it's a very, very old question which has now come. It is cry of baby in the womb. That is vagitus utrinus. Next question was match the following, where an amniocentesis image was given and you had to match it at what time it is done. All of you know that amniocentesis is done between 15 to 20 weeks. The best time to do amniocentesis is 16 to 18 weeks. Whereas chorionic villi sampling, the time it can be done anytime after 10 weeks of pregnancy. Best time to do chorionic villi sampling is 11 to 13 weeks, right? So best time to do amniocentesis is 19 to 20 weeks. Fetal organs cannot be visualized. It is not done between 8 to 12 weeks. Amniotic fluid assessment for alpha fetoprotein, yes. So earlier for neural tube defect, when ultrasound was not available, the screening test for neural tube defect was maternal serum alpha fetoprotein, and the diagnostic test was amniocentesis. You took out amniotic fluid and you checked the levels of alpha fetoprotein in amniotic fluid, right? But nowadays, screening and diagnostic test for neural tube defects is ultrasound, right? If they ask you which is the best biochemical marker for detecting neural tube defect, please do not mark the answer as alpha fetoprotein. Best biochemical marker for neural tube defects is acetylcholine esterase. Other than this, amniocentesis is also done for knowing about the fetal lung maturity, right? So amniocentesis, everything about amniocentesis I have told you in the main videos. Here are slides which are telling you differences between chorionic villi sampling and amniocentesis. Between chorionic villi sampling and amniocentesis is more reliable. This is because chances of fetal loss are less. It's more safer because chances of fetal loss are less with amniocentesis in comparison to chorionic villi sampling. And it is also more reliable. It is safer as well as reliable. Why it is more reliable? Because in case of chorionic villi sampling, you can get two cell lines. That is called as placental mosaicism. But that doesn't happen in case of amniocentesis. So yes, amniocentesis is more reliable and more safe than chorionic villi sampling, right? So these over here are other uses of amniocentesis. Therapeutic amniocentesis is done in case of polyhydramnios. It is used for fetal lung maturity evaluation in third trimester. In neural tube defects, earlier it was a diagnostic test. Now it has been replaced by ultrasound. In fetal hemolytic anemia, earlier it was being used, but now again it has been replaced by Doppler of middle cerebral artery. In acute fetal infections, torch infections, you do PCR of amniotic fluid. So this is all what I had covered in your main videos for amniocentesis and chorionic villi sampling. Okay, so coming to another question. The next question is arrange the cardinal movements of labor in sequence. Now, precisely for this reason, whenever I teach you normal labor, I show you the steps of normal labor so that you don't have to mug them up. All of you know that the first step in normal labor is engagement, right? And what do you mean by engagement? Engagement means when the largest transverse diameter of the fetal skull, that is the biparietal diameter, it has crossed the pelvic brim. That is what is called as engagement. Then the contractions, when they begin, it leads to descent of the fetus, right? And then once the fetal head touches the pelvic floor, because of the recoil of the muscle, the head of the fetus undergoes further flexion, right? And all of you know that the most common position during normal labor is LOT position, and for normal delivery to happen, that particular part which has to deliver, it should be directly behind the pubic symphysis. So from LOT position, the head of the fetus has to rotate and it has to come to DOA position, right? In other words, there is going to be internal rotation. With internal rotation, now the head of the occiput of the baby will be directly behind the pubic symphysis, and then with further contractions, the head of the fetus will be visible at the mother's introitus, and when the contractions will be relieved, the head is going to move up. Unless and until a time is going to come where, irrespective of uterine contractions, the head of the fetus will be permanently visible at the mother's introitus, and that is what is called as crowning. And this is the stage when you have to give episiotomy. If episiotomy has to be given, it should be given after crowning has occurred. Please remember, WHO does not recommend routine episiotomy in all females who are undergoing vaginal delivery to prevent perineal tear. That is not recommended by WHO. Then, with the movement of extension, the head of the baby gets delivered, and then there is going to be restitution. So when there was internal rotation happened, this 2/8 of a circle which the occiput had to move, this was aided by 1/8 movement by the shoulders and 1/8 by the torsion in neck. Right, so torsion of neck happened, and this is how 2/8 the occiput moved from LOT position to DOA position. It has to move by 2/8 of a circle, and this 2/8 movement happens because 1/8 movement happens of the shoulders and 1/8 happens because of the torsion of the neck. Now, the moment the head is delivered, then there will be the neck is going to untwist itself, and that is what is called as restitution. Right? Now the shoulders have to deliver, and when shoulders have to deliver, shoulders will have to come directly behind the pubic symphysis. So the movement of shoulders which occurs inside the pelvis, it is visible externally in the form of external rotation of the fetal head. So the next cardinal movement is external rotation. And with external rotation of the fetal head, actually the shoulders are rotating internally and they are coming to lie in AP diameter directly behind the pubic symphysis. The shoulders deliver, and then there is lateral flexion and the entire body of the baby delivers. Please, very important thing which you have to remember, that these days crowning and restitution are not taken as separate cardinal movements, right? So the higher textbooks do not take crowning and restitution as a separate cardinal movement. So this is the order in which cardinal movements happen. So let us arrange them. Engagement, that's the first step, right? Then there is going to be crowning. Then there is restitution, and then external rotation. So your arrangement is going to be capital A, D, B, and C. Clear to all of you? So all this I have explained to you in the mechanism of labor. True about ovarian cancer recurrence. Now, I will read out these options to you, but first you have to understand that whenever there is an ovarian cancer, for ovarian cancer, we go for surgical staging. In surgical staging, you are going to do a TH and a BSO. So you are removing the ovaries, and after surgical staging, the post-operative therapy of choice in ovarian cancers is chemotherapy. Ovarian cancers are radio-resistant, whereas on the other hand, ovarian itself is a very radio-sensitive organ. Rather, it's the most radio-sensitive pelvic organ, but ovarian cancers are radio-resistant, right? Except for dysgerminoma, which is a radio-sensitive ovarian cancer. So whenever you have to give post-operative therapy, in case of ovarian cancers, you are going to give a platinum-based therapy for ovarian cancer. The post-operative therapy will be platinum-based chemotherapy. Right? Now suppose if recurrence of ovarian cancer happens, and that recurrence occurs it occurs 6 months or later, then that is called as a chemosensitive recurrence which has happened, right? That is a platinum sensitive recurrence which has happened. But if recurrence happens within 6 months of stopping the chemotherapy, then that is considered as a chemo-resistant recurrence which has happened, or a platinum-resistant recurrence which has happened. So what I'm saying to you, you are giving a platinum-based chemotherapy to all ovarian cancer patients. Now, if recurrence is happening within 6 months, right, of the chemotherapy, then that's a platinum-resistant recurrence which is happening. But if recurrence is happening 6 months after 6 months, right, then that is a platinum-sensitive recurrence which is happening. Now, if it is a platinum-sensitive recurrence which happens, then the treatment of choice is carboplatin plus paclitaxel plus minus bevacizumab. Right? So bevacizumab is the drug which is a plus minus drug. Otherwise, you have to give carboplatin and paclitaxel. If it is a platinum resistant chemotherapy which you are giving, if it is a platinum resistant ovarian cancer, then the chemotherapy which you have to give for recurrence is either only paclitaxel or only bevacizumab. Right? So, this is very important as far as recurrence of ovarian cancers is concerned. Now, they had asked you true statement about ovarian cancer recurrence. This was a new question which was asked. Platinum susceptible if recurrence occurs in less than 12 months? No, it is platinum resistant if recurrence occurs in less than 6 months. Partially platinum resistant if recurrence happens in 6 to 12 months? No, there is nothing like partially platinum resistant. Right? It is either platinum sensitive or platinum resistant. Platinum resistant if recurrence happens at more than 12 months? No, that's wrong. Platinum resistant if recurrence occurs at less than 6 months? Yes. So less than 6 months is platinum resistant. More than 6 months is platinum sensitive. If it is a platinum resistant recurrence which is happening, you have to give only paclitaxel or bevacizumab. And if it is a platinum sensitive recurrence which is happening, you have to give carboplatin plus paclitaxel. Instead of paclitaxel, you can also give gemcitabine and plus minus bevacizumab. Right? So this is all what I wanted to discuss with you. These were the questions which were asked in INI-CET November 2022. If there are any questions which I have left or there are any options which came differently and what I have got is a different option, I'll be happy to take up all those queries which you have in the comment box. So just mention those things in the comment box. I'll help you with your queries in the comment box. Now, all the best for your upcoming NEET exam, but you still have 3 months to go for your NEET exam. But then these 3 months are less if you are studying properly, right? 3 months may all of you know that you have to put in at least 2 revisions just now. And for at least 2 revisions, you need 1.5 months for at least 1 revision. So there is no time which you people have to waste. This is the time when you have to just gear up your preparation and you have to, prepare yourself for that one final shot which you are going to give at NEET PG 2023. You didn't come this far just to come this far. You have come this far because you have to clear NEET PG 2023. So don't get disheartened. Don't lose hope. Don't quit. Just gear up for your NEET 2023 and I'm going to see you on the other side of NEET 2023. I just hope that all of you clear your NEET PG 2023 and all your dreams come true. Take care. Bye-bye.